Good morning, and 1,000 apologies for having reversed the schedule. I just don't know what happened. I gave my telephone number to my patients, and just as the chairperson, Dr. Sunita, knows that we were joined together for breakfast, and just as I was leaving, I got a call, and she was obstructing. She is my first 100-year-plus lady who's having an obstruction, and I had to handle that. My apologies. Now, that is Generation X. We have to care for our patients as such. Now, my first slide will tell you why am I creating this storyline. I have to start it from a history to the present stage, and then about mentorship, and then the future, and what is the call to action. To begin with, you have to reflect on the evolution of ID. The president had already stated how the ID scenario developed in India, and the Generation Z, okay, what they are going to face, and the generation hopefuls, what their future is going to be. So there is a shift from the legacy and to the reality of what is today, and you must have an outlook for the future. So we'd like to bridge this gap and then show you the way forward. Now, how do I create a generation gap? The era of Rohit and Kohli moved over to Gill and Sky. Steffi Graf moves over to Alcaraz and Sinner. My favorite, Sophia Loren and Audrey Hepburn has now moved to Alia Bhatt and Katrina Kaif. And Salman and Amir, etc. It all depends, or Ramcharan and NTR, because I was in Hyderabad. So I'm not trying to divide the gap, but I'm trying to bridge the gap, so that as we move forward, we have a better understanding of why we have this generation rumination. Why are we doing this? If you help and if you understand these differences, then it will help in better communication, leadership, and mentoring. I've used this word, communication, leadership, and mentoring. These three are the key words for the future, and you have to bridge this gap. Why do you want to bridge this gap? To bring your specialty, just like I showed you the examples of sport, music, drama. You want to bring your specialty, ID, into the mainstream so that the patients recognize you as a specialty. And please remember, this is the youngest kid in the block as a super specialty. Yes, emergency medicine in the broad specialty cadre. So you have got to do something special. And the purpose is, mentorship is not about teaching the next generation, but we have to empower you to take the practice forward in ways we never imagined. That's the thinking. I could imagine what we could do, and we have to move it. So let's begin. Generation X, I don't know the number. I've just taken 50 years and classified it as 1980. I tried to have several methods to divide this. NEET, pre-NEET, post-NEET, and it was too confusing for me. So I took it as simple, 1980s to 2000, and 2010 to 2030. So what about that 10-year gap? Call it whatever you want, Generation Y, okay? So I've just used this cutoff. Even sociologists do not have a good cutoff, okay, when this really began. You can call it as pre-digital, post-digital. I grew up during the time when I was scared to even touch the computer because I don't know whether I would get a shock. So that is the thing. So we moved from HIV/AIDS. And now, when I trained in 1980, HIV broke out in Los Angeles, San Francisco, and I was training. And I told my chief, I don't want to be trained in HIV/AIDS because HIV will not come to my country. So I spent my time working on AMR, clinical trials, etc. Bedside acumen, I used to get money as a registrar teaching postgraduates or residents in the US how to do a clinical examination, how to take a history, etc. So that's how I survived during my clinical fellowship days for infectious disease. So Generation Z is moving on to a different arena. The nibs and nabs, confusing to me. I know a few nibs and nabs, but for my specialty, infectious disease, broadly, I need to understand whether they hit at my B cells or whether they hit at my T cells. And then I understand. I don't know the names. They're all tongue twisters. So, you're moving into a different segment, and where you see infectious disease, that's coming up in different ways. Having said this, what you have to do now, the Generation Z, like I told you, I work 16 hours a week, sometimes even 19 to 20 hours a week in terms of really doing work. Narayana Murthy will tell you 70 hours a week. But when you look at your actual work practice, it is 90 hours a week. So you're paid only for 44 hours a week, but you do double time in order to ensure that you make a footprint or an imprint on your patients. Having said this, work-life balance, work-life blend. I never knew what it was. Sunrise to sunset, I was working with my patients. Today, it is 9 a.m. to 5 p.m. or 4.5, punchline, and out. So there's a difference in the work-life balance of what we see today and what we see in the earlier. So I'm going to address these issues. Who am I? I belong to boomers, maybe. I'm 73 years old, born during India's 5th independence. Today, you have to look at India's youth going to Viksit Bharat. That is your 100th year. Well, I think I will survive. I just had my health checkup done, my health span, lifespan. I think I've got 10, 12 years of good thinking, I'm thinking. So I've got to also practice. I'm also beginning life with youngsters, with all of you. You may call me, "Arey, what is this nearly departed guy coming up and speaking on stage?" One day you will find me as a constant absence in your life. But nevertheless, I'm going to say what I want to say so that you youngsters, or I don't see anybody younger than me, older than me, that's true. So what your ecosystem's going to be? So the best example is to start with me. This was me in 1969, and this was me subsequently in 2012 when I retired from Christian Medical College. I'm using this. This is my academic evaluation at my alma mater. My formative years, 12 years. And in these formative years, student MBBS, MD, Medicine 1 faculty, it's got a meaning here because Dr. Chandrasekhar and I were together in Medicine 1 at that time. Anyway, I was hostel warden. Why did I take the hostel warden? To have a better engagement with my students, and also because you get a bigger house if you are a warden as such. Then I became the HICC secretary. Oh, at a very young age, 81. Why did I become the HICC secretary? There were a lot of monkeys, bandicoots, squirrels, raccoons in my hospital. So the medical superintendent said, "Mathai, you have no other work to do. You try to keep the hospital clean." So that's how my career in infectious disease began, keeping the hospital clean of bandicoots, not microbes, all these macroscopic animals as such. Then because of that job, I got a fellowship posting in UCLA. Worked there for a year. There I learned clinical trials. There I learned animal models, creating intra-abdominal abscesses, and trying to treat them with teicoplanin and ciprofloxacin, ofloxacin, efloxacin, enoxacin, all of those antibiotics I worked with. Then came back. Then I had a 2-year fellowship in microbiology at University of Iowa. There I learned clinical epidemiology, hospital epidemiology, Richard Wenzel, Dr. Michael Faller for fungal infections, and then you heard about JMI laboratories. I got a good opportunity to learn infectious disease bits and pieces. Then subsequently worked with the Infectious Disease Center, and then the ACC. Bombay really gave me a lot of money. Churchgate Station, Cement House, ACC gave me a lot of money to develop the HIV care program at CMC Vellore. And then I moved on to acute medicine. So what did they do? The world we entered was different. We had a lot of clinical perspective, because I'm honestly standing here and telling you that I will not make a mistake in making an anatomical diagnosis histological diagnosis almost, or a pathological diagnosis. But etiology, I will make a mistake. You ask me amongst these 3,500 organisms, which organism did what, etc., I don't know. But I will tell you the pathological basis, I will tell you the anatomical basis, I have perfected that. But so, what did we do? This is because of mentorship of my seniors. Almost handled. Medical training began as an apprenticeship. And that is how we learned to take a history. I'm not working in a corporate hospital now simply because I cannot make a diagnosis in 15 minutes. Diagnosis I can make, but I cannot fill up. 45 minutes by my typing speed, zilch. Writing, no problem, because I used to write a lot of romancing letters, etc., so I still got my handwriting good. Okay, having said this, we built the systems. Infection control, no funding. Washing hands, no water. Drying. We had no systems available. So we built it. Hand hygiene, witnessed the misuse and use. That's malaria. That is typhoid. I don't know what it is, but give him an antibiotic. We did not know, we did not have great diagnostics. But anyway, we didn't have MDRO. I don't teach my medical students. I tell them don't use these 4-letter words, but try to learn something like Pseudomonas aeruginosa, or Campylobacter jejuni, etc. But we relied heavily on mentorship. And we had deeply clinical thoughts, but they always guided us. Now, having said this, I want to give you an example. Dr. Jacob John, is my guru, whatever. He spent a lot of time with me. I still preserve this. Dilip, what are you doing? General medicine. Come on, start doing something, epidemiology. This is his handwriting. I've preserved it. This is a handwriting to tell me, Dilip, why are we having typhoid fever in Vellore? Why don't you take it up as a carrier and make typhoid fever 0 in Vellore city? And with took a pen, paper, started writing. If I had to write this, you will find a lot of scratches, kacha-mucha, here and there, writing. That thought process was very clear. Why? How did this thought process become so clear? It's all on training and also the approach to the problem. I had several role models, okay? And several of them, and even from Bombay, I used these names, Dr. Ajita Mehta, Dr. Dastur, Dr. Camila Rodriguez. She was my examiner for my PhD. I hope I don't make any mistakes, otherwise you'll take back the degree. And I had pharmacologists, Dr. Molly Thomas, Dr. Shir Sagar, who is now the university vice chancellor of your university as such. So we were mentored. We were mentored in being a physician, being an empathetic physician, got the nuts and bolts of microbiology and pharmacology, the true ingredients for infectious disease. Having said this, so what shall I do? Should I be a general physician or a specialist? Radiology, no offense intended. Radiology can only tell you anatomy, contour, texture, fat, maybe arising from an anatomical structure, etc. Nephrologists, more about the nephron and function. The hematologists, they are experts at oncohematology and BMT, infectious disease. We know about infections. We know about microbiology, antibiotics, and extension of our MBBS, extension of our MD training. So what is happening to the Generation Z? Your needs are a little different. When you go through antimicrobial resistance, digital health explosion, I try to do telemedicine, okay? It's going to take me some time to learn how to better it, because you can't spend 45 minutes in telemedicine, no money comes. So you have to think, how can you make a diagnosis? You're not there to touch, feel, or smell. You don't know anything. So it's going to take a long time to make a diagnosis in telemedicine. The rates, my rate today is 500. Yesterday somebody said make it 1,500. Another person said go to 2,500. Brother, you need those clients. Having said this, you have to see new diseases that way. As I was leaving Vellore, I got a newspaper cutting snails and angiostrongiasis, tongue twister again, causing meningoencephalitis in Tamil Nadu. Now, you have to program yourself to 2047. This is what Vikshit Bharat. Yesterday, somebody asked me how many medical colleges, 801 plus 1, 800 plus 1. And I'm bringing out 100,000 MBBS doctors. And we have only today 33,000 postgraduate seats. And we have only about 12,000, all the super specialties seats. Even 12,000 is an exaggeration, but I'm adding fellowships and all of those, interventional radiology, et cetera. So you see now the health coverage of our people. Of course, Modi ji has said that we are going to be a forward nation. Maybe we're going to be a 30 trillion, 40 trillion, 50 trillion nation. Maybe you have the money. Doctors and workforce expanded. Who is your competitor? MBBS wala, who's your competitor? Homeopathy, Ayush, Ayurveda, etc. They are also looking at it. Also, they handle infectious disease. Anyway, so now we go on from MBBS, MDs, and then we go on to your super specialty. Now you've got a lot of trained microbiologists. What's the difference between a clinical I'm so happy that clinical microbiologist is interacting, because the training is different. The training competencies are different. William Osler, Louis Pasteur. Now 3 years bedside, 3 years benchside. Practical course only in microbiology, and then in clinical ID, you have to, we are clinical practice oriented, research, they are more research oriented. Communication skills lack because they don't see patients eyeball to eyeball. They're strong in epidemiology, public health, hygiene. Now, we can, in fact, you had a discussion yesterday on non-infectious causes. The microbiologist training does not allow them to ruminate on this. Pathophysiological concept may be better. Clinical localization, better. Molecular mechanism, they're better. So you see, there are different. Yesterday, we had a good discussion late in the evening, and we're talking about newer antimicrobials. How much do we really know about how antimicrobials work? We teach if the organism is susceptible on the lab side, you have a 90% chance of winning. If it is resistant, you have a 60% chance of winning. How did they develop this mathematics? Because there's so many other ways in which which this act. Secondly, I don't take it as an offense. You know only what the microbiologists discover. But what if they don't discover? You're zero. So you should understand all of these aspects before you look into what is the organism that is causing this person's fever. Now we have formed these criteria. We need trained people. Today we are having 17 DM candidates, 17 DM training slots for all these posts. And then it's only about maybe 17 institutions. 54 slots, 17 institutions. I'm having 800 plus institutions. When are we ever going to reach the target? Do we really need so many people? And I need 4 faculty to train somebody for 2 seats per year. Then you look at bed requirements. Tell me how many of us honestly have beds as consultants. We don't have beds. You go and see someone else's beds, patients in other beds. So we are supposed to have these beds. You don't get dengue fever now, or they don't admit them. Of course, some patients you admit. You have to have minimum of 3,500. We learned on volume. You have a large number of patients in the government hospitals, but not in the private medical colleges, which we founded. Okay, and then the number of cases. How many cases do you need to become an expert? This is what is given in our DNB program, CNS infections. 17 cases per year, you become an expert, or you can guide as a mentor, you decide. Say STDs 50 in a year, you decide. That is 17 in a year. So this is what the portion of the syllabus covers. We just get to see the touch and feel of some of this. And then, what do we do? So, what is the training of the generation X? What is the training of the generation Z? And then we have to go for this mentorship. So we have to have the skill transferred to the next generation, because you have to give them a psychological safety. And you have to ensure that they practice in collaborative research with all groups, radiologists, pharmacologists, microbiologists, etc. So now, mentorship is a hierarchical profession in which experienced practitioners guide apprentices. Now, Dr. Subra, sorry, he was my mentee, I was his mentor. Today I will say, I am his mentee and he is my mentor for transplant infections. You see how the roles get reversed. And so mentoring models must evolve, okay, from teaching to coaching. Giving them the psychological safety, structured exposure. It's not a question of a teacher can fix a student. A teacher, it will not reveal his entire knowledge to make it easy for him or her to understand. Unless you have this strong mentorship idea, plans, you will not do it. We are not great in global health. We don't speak about global health. We see only something around us. Now, what Generation X must pass on to Generation Z, what we'll learn from Z. Well, so many things that we can learn. And well-being focus. I don't know whether I should regret this statement of mine. I was wrong, making people work 25 hours a day and 8 days a week. I don't know, Sibara still loves me, so it's okay. And so we have to pass on this. I don't appreciate pattern recognition in ID. In dermatology, pattern recognition. In ID, pattern recognition is you have to begin with history, physical findings, make a clinical diagnosis, and then you choose your laboratory methods, tests, diagnostics, and then you plan on your treatment. Okay. Having said that, we just move on to how do we bridge this? It's a shared mission. X and Z, it's a shared mission. We have to work with each other. We have to ensure that we are at the bedside of the patient when they see the patient, and make sure that they see the patient properly. Empathy. I am examined at 19 universities and done more than about 65 examinations, but they don't understand empathy, and we don't give marks for empathy. We don't give marks for skills at compassionate care. You can pass general medicine MD without knowing the treatment of typhoid fever or without even examining the patient in the correct, courteous manner. We should never forget that as consultants. You may be an infectious disease specialist, but don't ever forget that. So bridging the gap, hierarchy. Yesterday I was talking about hierarchy. Hierarchy is only for discipline. I can learn from Subra, I can learn from Dr. Sunita. I may have at one time been their senior level people, but that doesn't matter. You can learn from anybody. And you have to encourage innovation. I promised I would listen to Abdul Ghafoor's talk, innovation. It's a nice concept which is got. I hope he takes it forward, but I am not able to bless him on that because I myself am trying to be innovative as such. And collaborative research. And Generation Z, multicentric, cross-disciplinary work. Please understand, every single healthcare worker, you need them, they need you. Don't ever say that I can't handle with them. Teach them how to get their skills upgraded. I spend a lot of time with infection control nurse. That's why yesterday I said we should train nurses. They are the shoe leather. They are the ones who work. And the curriculum really needs to change, both at the MBBS level, and then at the internship training, internal medicine training level, and become a lifelong learner. Today is easy to learn because you've got so many ways in which you can do. So having said this, we go on to the last part of it. 10 things are needed? Everybody will, do I want to expand my ID training program? You are going to have so many doctors. Will we be having enough patients? Would they be able to make their money? It also depends on how much money you want. I have estimated, I'm now retired, I have estimated I need 2 lakhs per month. Only then can I keep my household going. Do I need to save money for the Generation Z? No. Why? Because they can also go through the whole thing that I went through. But if there is anything left behind, it's fine. So you have to fix what money you need. And how many hours, how many hours? 2,000 per hour or 2,500 per hour, and work accordingly. You can't, you're not a proceduralist. You can't make money from services, but you can make money if you have a laboratory or if you own a scan center. That's the only way you can make money. But as a consultant, it's only as you see patient. Then undergraduate and postgraduate training, then strengthening AMR, all these are public health. We don't get involved too much with public health work. We talk, but we don't get involved. Advanced laboratory training. Would you spend 3 years of your life and go and train yourself in a laboratory? Am I missing out on patient care? I don't think so. Research, no funds. And time has come when the postgraduate DNB student is spending his own money to do research. I don't like it. I will not approve of it, but situations are like that. And then accreditation, mentorship, and continuous learning. Now, continuous learning is what? I graduated with the 11th edition of Harrison. Today, the 22nd edition of Harrison has come. What is the gap? Did I catch up? You know, you should understand that continuous learning. And then levels of mentorship, roles and responsibilities of mentor, mentee. And then you can't do research without a mentor. Please, don't ever think that you've got brilliant ideas. You still need to get them done. Professional networking. Today, I've got a 62-page CV. It's of no value. I showed you my, let's say, you know, the citations, etc., some value for my promotions. Today, for assistant professor, we have rankings and ratings. So about 20 is good, I reach 40, but my HDL cholesterol has not gone beyond 40. It's hovering around 38. But you know, you have to have these numbers. And my message to the anxious generation is, how do you have this love affair? First, you have an interest in a person. Then you have a fascination for the person. You had an interest for infectious disease. No, I had an interest for anatomy, microbiology, pharmacology. Then the next one is passion. Passion is when you have an action. Action means when you jump into ID. Action is when you put in the ring in the ring finger. So that is, so you must have that fascination and the interest, and then passion. Why I'm saying this is I'm 73 years old. I still have the passion to go for another 12 more years. Maybe ID and internal medicine. So for my actualization of my dreams. So you need these transformational tools. I still read. I continue my learning desires, etc. So to summarize, for Maradona, Messi is his hair. You want to say Messi, Maradona, well, years apart, but both of them are landmark figures. I also try to emulate them, but this is what has happened to me. I sit in my dean's desk. And my hope for the future is my grandson would take up infectious disease. I see no way about it. So I'm thinking of offering him mentorship to take up ID. Thank you very much for your patient listening. You can have these slides free of cost, but if you make money, give me some.